I'd like to remind everybody that when you speak, please identify yourself before doing so we know who's talking. And saying with that in mind, this is Grant Ritter, chair of the committee.
Dr. Ritter, before I do the roll call for attendance, can I just mention that this meeting is being recorded for minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live-streamed on the Access Health CT website. Thank you, Mr. Chair.
Okay, so could we begin by taking roll of the attendance, please?
Yes, Mr. Grant Ritter, Chair.
Here. Yes.
Sean King.
Here.
Mark Schaefer. Matthew Brockman. Manisha Sutani. And Tun Goen.
I'm on.
Thank you.
Oh, good.
We do have a quorum, Mr. Chair.
Good. Okay. Next on the agenda, I guess there's no public comment. Is that right? Nobody's.
That's correct, Mr. Chair.
Okay.
And would you like to welcome a future member of the committee?
Yeah, right. I see. By the way, we are joined today by John Warkula of Molina Connecticut as our new representative from Connecticut. He's not a board member yet, but we will be voting on appointing him as a member to the committee as soon as the board of directors meets next week. So welcome to the welcome to the committee, John. Okay.
Thank you.
Sure. So
we did not receive any public comments. Mm-hmm.
Next, if we could have a motion to review and approve the minutes from our last meeting, which was actually back in February 2025. If somebody could make a motion to approve.
So moved. This is Sean.
Thank you, Sean. Seconded?
This is two. Second.
Two. Thank you. All right. Are there any edits, changes, comments about the minutes from last year? I know it's a long time ago. Okay. If not, could we have a roll to accept the minutes?
Grant Ritter?
Yes.
Sean King?
Yes.
Mark Schaefer? Matthew Brockman? Tun Goen?
Yes.
And Manisha Sutani. Thank you.
Thank you. Thank you. Okay. I guess I can turn it over to Kelly now to talk about the mission and vision and mission of the Access Health.
Good afternoon, and thank you, Dr. Ritter. Happy New Year to everyone who is on the call. I'm going to apologize up front if my voice goes in and out. I am trying to get over a cold. So on the screen in front of you is our mission, vision, and value. This is what this is our mission of the company and what we're trying to obtain, our vision and values that all of our employees share. I'm not going to go through it word for word. It's on the screen, and it'll also be in the presentation that is uploaded up on to the website. So I'm going to get right into it. So Martin, if you could go to the next slide. Generally at this time, I just wanted to start the conversation off. Usually by this time, we have already received guidance from CMS. This year, we have not. Typically, it's received somewhere October, November timeframe. To date, we haven't received anything, although if something's come in today, I may not be aware. So I'm just prefacing this conversation to let you know that we're already kind of starting out the gate a little bit behind schedule, but I want to help everyone understand. I know that there's some new members to understand what the cycle is for plan management, and then what the requirements are for this group as far as meeting certain guidelines and milestones. So the plan management certification life cycle really starts generally in November and goes through about the April timeframe, where we're going through regulations and guidance. We're meeting with this group. We're having discussions about plan designs, what we think our consumers need, and making any recommendations or presenting recommendations to the board of directors. And so, again, usually in January, after we do this part of the presentation, we would start to have those discussions because we would have already had conversations with all of the issuers to run information through the actuarial value calculator to see where they fall, which would help us start to have discussions on determining what kind of changes we would like to see coming forward. So during that time, we're looking to develop the standard plans and the certification requirements. So that would be from December to March, with March being our first milestone which is releasing the solicitations to the issuers, or to the public, I should say. So any issuer that is interested in potentially coming to the exchange for the upcoming year, they could go out to our website, start to look at the draft requirements for the upcoming plan year. November to August, we're looking to make portal enhancements and test those changes and roll out into our system. But our milestone 2 is the release of the application. And that we generally try to release that information in March and April of the same year, so that it gives all the issuers who are looking to offer plans on the exchange a substantial amount of time to be able to make sure that any changes that may have filtered down from the solicitation into the application, that they'll have enough time to be able to incorporate that into the rate filings. Because we also, while the SID is requesting rate filings on June 1st, we also ask that the applications be submitted to Access Health on June 1st as well. And that would be our milestone 3. Milestone 4 is late October, where we're certifying the plans and ultimately getting everything completed, uploaded into our system, tested by our issuers, and ready in production for our consumers to look at the information for open enrollment, which is November 1st. Go to the next slide. To meet those milestones, this is what this group will be doing. We started our first meeting today. We need to wait for CMS to release any of their draft guidance. We're not sure if it's going to be draft or if it'll be final. And then as that information comes through and we continue to have conversations, we will present any of those recommendations made by this group to the board of directors. We expect to do that on March 5th. I'm going to caveat that, though, based on when CMS releases the information and how quickly all the issuers can go through the information, test their plans, and we can come up with plan options, and how the discussions evolve on this group will dictate whether or not we hit that March 5th date. So I do want to stay at this time. Our HPBQ meetings are scheduled for every 2 weeks. But based on what we're seeing right now, we may need to schedule another meeting in between, or maybe move meetings around. So I just wanted to make sure everybody was aware of that as we start to get into this. So again, that's those first 3 components. Those will help us get to milestone 1, which is releasing the solicitations. And then if the information that CMS provides to us is not in a draft format, we'll obviously have to wait until it's final. And then if there's any information from the IRS that we need to wait on, we'll have to wait for that information as well. And that will help us move into milestone 2, which is releasing the application. And then getting the issuers to be able to respond to those applications by June 1st. We want to give them an ample amount of time so that they may respond appropriately. Before I move on, are there any questions with these timelines? No?
I have a question.
Sure.
How much of the delay was due to the shutdown, and if there's another shutdown at the end of the month, is that going to, be catastrophic for us?
Yeah, good question. I apologize. I just don't have an answer. Oh, maybe Susan does.
So sorry, Grant. Yeah, I also do not know if anything was due to the shutdown. What we've heard is that the calculator, the draft AV, should be out, I think, next week. So that's a really important one for us. But we don't know, and we won't know until the end of January. But I don't think there will be another shutdown. But I'm not in charge of that.
Yeah, I
But
know. I understand.
yeah,
But Grant, we do know the shutdown had impact across the CMS organization because the folks that Susan and I normally meet with, and that access meet with on a regular basis, they had canceled meetings
Yeah.
because of the shutdown. Right? They had one person, rotating. So we know it had an impact. Whether or not it was a direct impact to to this particular situation, we don't know. But we know across the board it was definitely impacting staffing, consultants working with them.
Right. It does sound like the important thing is to get the calculator
AV.
to us
Yeah,
before
yes.
the end of the
Yeah,
month.
Yeah.
Absolutely. That's the crux of what we do. So yes,
Then the ball's back in our court. Yes.
absolutely.
Yeah.
Hurry up and wait. Okay. If there aren't any other questions, we can go over the requirements. So the certification requirements, this is a list of items that we may have discussed in previous years. And so the dots recommend, the dots actually identify whether or not we made modifications in 2026 or if there are suggested topics for 2027. So in 2026, the only thing that we modified was the standardized plan designs for the individual medical plans. But for 2027, there are a couple of items that we would like to talk about. So one of them is broker compensation, and then obviously the standardized plan design for individual medical and dental plans, or the SADP, standalone dental plans. So unless nobody has any other recommendations, we can go on to the next slide. So this year has been quite quiet as far as changes from the state. There was one change this year that will be impacting the plans, and it's expansion of coverage for behavioral therapy. I'm going to just summarize the actual change has been listed in the big paragraph, but essentially what they're doing is they've expanded the insurance coverage of applied behavioral analysis services for individuals diagnosed with the autism spectrum disorder up to age 26. So I suspect that all the issuers on call are aware of that change. If not, here's the information and the Public Act number if you're not familiar with it. Next slide. So permitted plans, we have no recommendations at this time to make any changes to the permitted plans. At this time, with exception to the standalone dental plans, no issuer offers the maximum amount of qualified health plans on the exchange. So I don't know if anybody wants to engage in any conversation, if they disagree. If not, continue on. Okay, so I'm going to introduce Ren. Assuming Ren is on. Yep, there she is.
Yes, I'm here.
There's Ren. Ren, we have engaged conversations with Ren from Wakely Consulting to kind of start the conversations on what we think we should do this year. In the past, our focus has really been on AV and making sure that benefits are at a level that are um, beneficial to our consumers. But with everything that has happened and the elimination of some of the tax credits, obviously cost is a factor, and that's a big conversation that's happening all over. So Ren is going to lead that conversation for us to maybe get the engines moving, and hopefully we'll be able to get some ideas out of this as far as how or which way we would like to go. So with that said, I'm going to hand it over to Ren.
Okay. Hello, everyone. Yeah, I'm Ren Song, consulting actuary from Wakely. And I really appreciate the opportunity to share our approach to evaluate the potential changes for the standard plan design with a focus on bronze and gold. So we, after a conversation with Kelly and Susan, which I really appreciate all the information, we recognize the concern that the rich benefits of expanded bronze plan has widened the pricing gap between bronze and catastrophic plans. And our goal is to assess whether a leaner bronze plan or an extra leaner bronze standard plan could be better support affordability and consumer choice. For the standard gold plan, we acknowledge that it offers the richest benefits and consistently exhibits the highest loss ratios. And it also has, it's a lot more expensive than non-standard gold options. So we'll evaluate whether the standard gold plan design should be leaner while continue to provide strong value for members who need more comprehensive coverage. So the approaches we were thinking, Kelly did a lot of research on this, like we modified the drug benefits, out-of-network benefits, or even separate drug deductibles. That's a very rich benefit. Right now, the drug that have a separate deductible, which is very low. Things like that, we can do deeper research and find out which lever will be most effective to modify the plan design. So we'll also take be mindful to take a market-wide view in this work. We realize the market is an interconnected system, and we change one tier may affect others. So we'll work closely with Kelly and this committee and the issuers to find solutions that are balanced and practical. So once the 2027 AV calculator becomes available, we'll be able to test the specific plan designs in detail, and we'll also leverage Wakely's pricing models and the ACA databases to support the analysis. So this will allow us to identify most effective adjustments to plan design and bring recommendations back to this committee for consideration.
Thank you. Are there any questions for Ren from the committee?
Can I
Another
ask?
question.
Yeah, go ahead. Who was that?
Sorry, this is two.
Yeah.
I do have a recommendation. One of the things that we do see on our end is there's a lot of utilization of services outside of state. And I think that probably due to the products that we offer, like for example, the standard plan today that we offer, it has to be either a PPO or POS. So there's a lot of members because of the product itself. There's a lot of members go to states like Florida and California to utilize the service. So if there is a way to consider to have either an HMO or an EPO to avoid some of the out of state utilization, that could be a potential savings of claim costs.
Right.
This is John Carbone. I got a quick question for you. Aren't all the plans in Connecticut for small group and individual only Connecticut-based in-network service? So you're talking about the utilizations that are being used as the ONET benefits, not the PAR benefits?
It is because of the out network, and I'm going to use Cover Connecticut as an example.
Understood.
Because the states are basically subsidize the cost share regardless of the members going in network or out network. So the members, we see a lot of Cover Connecticut populations because they don't pay the cost share, utilize services all the way to in Florida or California. So to me, unless we change the way we subsidize the cost share for the members, or we change the out network kind of benefits, it avoid the issues where members go all the way to Florida or California to utilize the benefits.
Do you have any statistics? And I apologize, I didn't identify myself. John Carbone, Director of Small Group Product Development, Broker Support. Do you have any statistics about what the cost savings would be?
We can definitely.
Hey, John, maybe this is something that we could work directly with Anthem outside of this meeting. All right. I had this conversation with Lou earlier in the week, and we understand this is an issue for Anthem, a very serious issue. So maybe we need to put together. Granted, this will impact plan designs going forward. I understand that Lou mentioned that to me, but maybe I don't know if we want to tie up the whole committee with this very runoff item. So can we get with you, Lou,
yeah, we can
very soon, right? And so that if we have any recommendations, we could bring it to the committee and maybe explain to the committee in more detail.
And this is Susan Richby, just to add the parameters of the Covered Connecticut program are not set by Access Health Connecticut, that's set by the state of Connecticut. And while, a substantial portion of enrollees in Silver plans are in Covered Connecticut, it is not limited. Silver plans are not limited to Covered Connecticut enrollees. So that is not, all of the enrollment. But to James's point, I think that's a separate conversation.
Yeah, I think
Right.
to Susan's point, I think that is an issue that is a statutory issue with the way Cover Connecticut is developed, not necessarily an Access Health plan design question. But if there's other solutions, always.
Yeah.
I do have a related question though, which is, can Wakely work with the carriers to figure out, what parts of our plan design do folks use and enjoy? And what do they not care that much about, and maybe only a very small subsection cares about, but we've kept the copay low when we shouldn't, and things like that. And I'm sort of curious in terms of utilization and experience. I feel like we don't always bring that into this conversation, but as we hopefully in this year focus more on overall affordability, was it just the AV calculator kind of thing, but the cost of the plan, having a better sense of what are the insureds are using and not using and care about and not care about. I'm sort of curious, the more information we have on that, the better.
Yeah, that's definitely on my list of research. I'll definitely look into it using our pricing model and our ACA database. That's a very valuable tool to just answer your question. That's exactly what we are going to do, because the AV calculator is just a very high level. It doesn't have it close to the pricing, but different. So the real pricing, for example, like generic drugs, they might be a pricey item in the pricing, but doesn't affect much in AV calculator, vice versa, things like that. So I think, yeah, there's disconnection between AV calculator and the real pricing. we will look into that to see what benefits are more valuable to the consumers, and yeah, we'll go from there. Yeah, good advice.
Thank you,
I-
Ren. What's really major is that the drug benefit, I believe, is used by vastly more people than
Yeah.
the medical benefit. But and I would really hate to get rid of the separateness of the drug benefit for that reason. I mean, it's got a low copay. I mean, a low deductible. You're
Yeah,
absolutely right.
very low deductible. Yeah.
But it's really the thing that people take advantage of.
Yeah, and the silver plan, excuse me, specifically has always had a separate deductible for the drugs versus the rest of the benefits.
Yeah.
Yeah, I'm taking notes. Yeah, there's certain benefits. There's a reason it's there to begin with, right? So definitely need to know.
Mr. Chair, can I just jump in with something real quick too?
Sure.
And this is, it seems related to me to the issue that Sue raised, but also may not be exactly on topic, but our office is running into an issue with Anthem products where they're denying coverage for services that are provided out of state because they're claiming that it's out of the service area. So I'm a little confused about the intersection between that issue and what Tu is raising in terms of all these additional benefits being provided for people who are getting care outside the service area. And I think it's important because we do have a lot of families who enroll in Access Health plans through Anthem, and they have adult dependents who are going to school out of state and things like that. And it's not squarely on point here when we're talking about, where do we set the deductibles and copays, but it is a plan design issue that I just want to flag. And maybe that is also something, James, that should be part of the conversation you have with Lou and the team over at Anthem.
Well, Sean, maybe you should be part of the conversation with James and Tu.
I would be happy to if
I'd like to know the
Thank you.
circumstances, because I sort of feel like if it's a PPO or a POS, the copay might be different or the coinsurance might be different, but I thought it still was covered.
Well, that's why it's an issue that we flagged here, and we don't really have a resolution to it. But it's, again, don't want to belabor the point too long.
Yeah.
Here.
So, Grant, would it be appropriate to create just a quick subcommittee?
A subcommittee? Yeah.
Yeah, of your committee working with us, and obviously the two carriers should be on it, and along with some board, some committee members. But we're happy to take the lead and coordinate that. So
I think that'd be great.
Okay.
Yeah. Yes,
And
certainly.
okay, and whoever's this committee is going to move pretty quickly because we have to get this thing back to this committee, and so that the plans to use Matt's comments. Our focus this year is affordability. How do we make everything that's in the exchange more affordable for Connecticut residents?
Exactly.
So, and this committee needs the information to make those decisions before it goes to the board. So we'll take that, Grant, let us know who's in the subcommittee, and we're taking a run with it and get something back to this committee as quickly as possible.
Great.
Yes.
Thank you. The issue for the year.
Yeah.
Okay. Are there any other comments or questions for Wakely? If not, John, would you like to take over? Yeah.
Yes, sir. Thank you. Good afternoon,
Thanks,
everybody. John
everyone.
Carbone.
Yes. Thank you,
Thank you,
Ren.
Ren.
Thank you, Ren. Good afternoon, everybody. Director of Small Group Product Development and Broker Support. Talk a little bit today about broker compensation and what we've been doing to help our current members and the members who are coming to us that are not assigned to a broker. As many of you know, the compensation for brokers has changed in the marketplace for 2026 drastically by both carriers. Our focus and concern was making sure the members who did not have a broker assigned to them were going to be able to get the help they needed. So Access Health has basically developed a program in-house. We have hired 8 brokers that will help all unassigned members that do not have a broker on walking them through the program and having them understand the benefits and what they can do with Covered Connecticut, Husky, Small Group, Business Plus, any products that we have available. They are responsible for tracking it, marketing in our systems, being able to take calls, make appointments with these members, and walk through the entire steps. Throughout this process, currently they've been on now for about 3.5 weeks, 2.5, 3 weeks, and we're currently compiling all the data. We've gotten great feedback regarding their utilization and how helpful they've been to our communities, which has helped relieve some of the stress. And they're also helping some of our current brokers who have a big caseload and being able to walk them through and making sure everybody gets renewed for 1/1 and 2/1 as we go through that process. On top of that, we plan on keeping 2 of these brokers on all year long. We have it budgeted so throughout our fiscal year, and we're going to keep these brokers on, and those brokers are going to continue to help with special open enrollments, individuals that are calling us, going to help with our Business Plus product also, and they are also going to help with healthcare literacy and also helping each individual member make sure that they do set up a primary care doctor and make those appointments and schedule them and keep them and go to them, because there are better outcomes with them when they do that. So that's where we are currently right now with our broker program that we've established. And if anybody has any questions, I'll be more than happy to answer them.
So, hey, John, very quick, I just want to put some context around the reason why we're doing this, because both carriers have substantially reduced the commission brokers have received in prior years, and we think that may lessen the brokers' willingness to help people on the exchange. Right. So that's the biggest reason we're doing this. So to get ahead of that possibility, we didn't hire them. We contracted with them because I think the law forbids us from hiring brokers. So we have contracts. They're not employees of the exchange, and we will keep 2 of them on throughout the year to help us to help those folks who are new to health insurance. Make sure they have a primary care. Make sure that they can call them and help them pick a primary care that's in their plan, and also help make sure that they have a annual physical schedule, follow up with them. Again, just typical stuff that's going to help improve the quality of life, quality of health, and hopefully in the long term lower costs to everybody.
Yes.
All right. So, but again, we're doing this to backfill potential gap that may arise as a result of lower commission for the brokers.
Okay. I guess we can now move on to Kelly to talk about next steps.
Well, so the next steps. We will wait for CMS to get us some information as far as the AV calculator and any other guidance. And what will end up happening is Ren from Wakely will be contacting all the issuers with the expectation to run their current standard plans through the new AV calculator to see where they fall, and we'll look for suggestions from both issuers to, as far as plan design is concerned, should they be out of range, we would look to them to provide any thoughts or plan design options they thought they would think would get them back into range, and also to think about some of the things that we've talked about today, and hopefully have some thoughts or considerations as far as plans going into 2027 and how we think that we might be able to bring down the cost of those plans. So depending on how quickly this information gets to us may dictate either us moving a meeting around or scheduling additional meetings, as I had mentioned earlier within the presentation. And I also just noticed that I didn't introduce myself. So for those of you who don't know me, I'm Kelly Cody. I'm Plan Management Manager here at Access Health Connecticut.
Okay. Okay. Thank you.
Thank you.
Thank you all for this meeting. I guess I'll entertain a motion to adjourn from some board member, some committee member.
So Grant, we'll reach out to get members of the subcommittee, so we get started right away. Okay.
Right away. Absolutely.
Okay.
Yes.
Thank you.
Okay. Can I have a
Matt
motion to
Brockman,
adjourn?
move for adjournment.
Thank you, Matt. Seconded?
Second, Sean.
Sean, thank you. Can we have a roll call vote?
Grant Ritter,
Yes.
Sean King,
Yes.
Mark Schaefer, Matthew Brockman,
Yes.
Jun Goen,
Yes.
and Manisha Tutani. Thank you.
Yes.
Oh, thank you, Commissioner Tutani.
Thank you. Until next time, thank you, everyone. We're adjourned.
Thank you.
Be well.
Thank
Thank
you,
you,
everybody.
everybody.
Bye now.
Bye.